Okay, I want to welcome everybody to the Resident and Family Support Council. We hold these on the second and the fourth Tuesday of every month at 3 o'clock. And we always use the same link to be able to get to these meetings through Zoom. And I want to thank the Illinois Pioneer Coalition for allowing us to use their Zoom account in order to be able to host these meetings. So thank you to the Illinois Pioneer Coalition for that. What we do with these meetings is we try to engage people in conversation so that we can feel empowered as we're navigating this long-term care path. And we get a variety of people who attend these meetings. And I really feel we get a lot of wonderful feedback on them. One of the things that I did want to bring to everybody, and I'd love your feedback in the chat, if you could give that to me. We've been talking about the format of these meetings and wanting them to be more engaging for people. So one of the things we have thought about is every other meeting to basically do more of an open forum where people could ask questions, bring up topics that are of concern to them, and have it a little bit more of a dialogue as opposed to just a presentation, as well as the questions and answers that also occur. So if you are open and would like to see a dialogue happen on every other meeting, please put that in the chat for me so that I know. We're going to go ahead and give it a shot for a couple of meetings to see how it goes, but I would really love everybody's feedback as well. I see we got a resident group there. Hi, everybody. I see we've got some people back there. Great. Feel free to unmute that microphone if you guys wanted some questions to ask. We love to see people come together to share in these meetings. So with all that being said, today we're talking about ADLs. We're going to kind of get to what is all this all about? Activities of daily living. We hear about this a lot, but we don't always recognize really what this is and who does what and what is therapy all about. And so we actually invited Ryan, who's the director of rehab for Symphony of Evanston, to come and join us today. I see that Ryan is here. Ryan, hi, Ryan.
Hello, how are you?
Good. I just want to share a little bit about who Ryan is. Ryan is actually a speech therapist who has been working in long-term care since he graduated in 2017. So he's been doing this for a while, working with those that live in long-term care. And he's the director, like I said, of the Symphony of Evanston. And he actually works for Select Rehab. That he's been doing since he graduated. So he's been somebody who's been doing this for quite a while. And we're really open and excited that Ryan will be able to help kind of navigate some of this conversation for us today. So Ryan, I'm going to go ahead and I'm going to open it up to you to share with us a little bit about what this ADLs, activities of daily living, is all about. Can you explain that to us? What are the activities of daily living?
Sure, thank you. So first of all, thank you for having me here today to kind of explain on this. Sorry, I can't, share my camera. It's limited on my company computer. So yes, ADLs are the everyday basic tasks that you or I do without even, what someone might do without even thinking. ADLs are any fundamental skill that you need to care for yourself. Examples of ADLs are walking, getting in and out of bed, dressing, bathing, hygiene, grooming, toileting, feeding, just to name a few. There are many. It's basic tasks, basic skills that we do each day to care for ourselves.
Okay. And so these skills that we're doing that we, to take care of ourselves, if I go into a long-term care facility, do I continue to do all this for myself? Does my nurse's aide do it for me? Do I have therapy do it? Is the nurse doing it? Who does all this stuff?
Sure. So it's kind of a continuum, and I'll kind of start from a therapy standpoint, obviously my area, and then segue into when the transition to long-term care occurs.
Great.
So the therapy standpoint, obviously patients or residents come in either with the goal of short-term and the goal of eventually transitioning to long-term. But when they first come to our facility, we have physical, occupational, and speech therapy to assess their current levels and get some prior level on their background. From a therapy standpoint, we'll then work with the residents, with the patients, to try and regain any lost function. They might have come to us from the hospital. They might have come to us from an assisted living or independent living where they've had some form of physical decline or medical decline where they're needing some more help. So we'll work with them from a therapy standpoint to help regain that function. So physical therapy, for example, I would work on balance, walking, getting in and out of bed. Occupational therapy, then we can work on feeding, dressing, bathing, hygiene. They'll do those actual tasks with you in the therapy sessions themselves, kind of to measure to see how much help you are needing and what areas we're going to work on specifically. You might need more help with dressing versus bathing, and that's something that therapy, while the resident is receiving therapy, the therapists themselves can help you with. Obviously, the goal is to improve independence, improve function. We want the resident to be able to do as much as they can for themselves safely, and we're there to help facilitate that, to help them regain those functions as much as possible. But for some, obviously, then when the therapy kind of comes to an end, and if someone is transitioning to long-term care, those tasks would be handed over to kind of a few different people, the CNA and the nurses being kind of the key factor in that. You know, we as the therapy department will kind of establish a program of what each individual resident is able to do, what they might need assistance with, what areas they might need assistance in one portion, but not in others. So we then transition over to the CNAs and let them know, for example, they might need help if we're talking about dressing. They might need help dressing the lower body, shoes, socks, pants. They're able to do the upper body on their own if you hand a shirt over, hand a jacket, hand a hat. So it is a kind of a continuum of care in that aspect of who kind of follows through with that. Again, our goal is obviously to promote independence. So kind of like what you said, it's not it's not as if you're responsible to do everything for yourself. We hope that you can do as much for yourself as possible, but it kind of comes down to, being in long-term care, it's kind of expected that you might need a little bit more help, and we're there to kind of fill in those gaps. We being, again, the CNAs, the nurses, anything that can't be done on your own or can't be done independently, the CNA or nursing staff is to help carry that out.
So you mentioned, you started with this therapy piece, and
Mhm.
I got some questions around therapy.
Sure.
So I'm in the hospital. I come to the facility for what gets termed as rehab.
Mhm.
And so what would I expect to see? I'm coming in, I've been in the hospital for 2 weeks, let's say, and now I'm being discharged to a rehab center. Now, what do I expect as I go in?
Sure. So kind of starting at day one. So you're discharged to our facility. You have your room. Everything is provided to you. You have your bed, your pillow, your blanket, your TV. You're set up there. The morning after, the therapy department will come in, the physical, occupational, and then speech therapy if needed, to do their evaluations in that first day. Within the evaluations, we'll be assessing kind of a handful of different areas: physical therapy, assessing bed mobility, walking, transferring to and from the bed; occupational therapy, like I said, addressing bathing, hygiene, dressing, both upper and lower body, feeding. And then we'll develop our plan of care based on the current levels. We'll review your history, speaking with you, speaking with your family, whoever your loved ones may be, family, friend, to learn about what your prior level was, what you were able to do before this all happened, before you were in the hospital. And that's kind of how we establish our goals. Our goal, again, ultimately to get you back to where you were before the hospital, before you had any form of decline. Obviously, therapy doesn't happen 24 hours a day when you admit to the facility under short-term from the hospital. It's only at most maybe 2-3 hours of your 24-hour days. And kind of what does the rest of your day look like? On the short-term floors, we again have the nurses and CNAs. We will endorse to them after our evaluations. I saw room 101, they need assistance with feeding. The assistance they need is just for it to be set up. Put the food in front of them, open the drinks, and they can feed themselves. Or we would let them know that they need a complete assistance or total assistance with feeding. They need someone to sit with them and feed them each bite because they're physically unable to. We endorse to the staff to to maximize the carryover, because again, therapy isn't your whole day when you first admit. They need to have someone else, again, the CNAs, the nursing, to help carry that out when therapy isn't there.
And so should I expect to see this on the weekends as well or not? I mean, I understand people need to have days off, so I'm not sure what that looks like. Is it every day of the week? Do I get
Sure.
therapy a couple of times a week? What does this look like?
From a therapy standpoint, in the terms of the therapy sessions, the facilities I've worked in, therapy is typically 5 days a week, and it's typically a Monday to Friday. That being said, there are exceptions where people will come in on a Saturday or Sunday, and then you'll have a day off from therapy during the week. But that doesn't mean the assistance with those ADLs is gone during the weekend. Again, you have the CNAs and nursing to help carry that out, but the therapy sessions themselves with the PT or the OT usually does not occur on the weekends. What we typically do is in the first couple of days, we will provide kind of like a home exercise program, a little handout of things that you can do on your own. Again, the therapy is only a short part of each day, be it the weekend or the weekday. We can only help someone as much as they want to help themselves. They need to, these home exercise programs are things they can do sitting in their bed, sitting in their chair safely to help facilitate the regained function.
So it's sounding to me a lot like if I didn't go to a rehab facility and I was just going to therapy, it sounds like it's similar in that fashion, in that there is some expectation that I go to therapy, but then also I should probably do some stuff on my own too to help my progress.
Definitely. That is a big kind of expectation. Again, time being the biggest factor. 22 hours of the day, you're not in therapy. You're not getting therapy. You're in this rehab facility for rehab, but what do you do the other 22 hours of the day? Obviously people need time to relax, to recover. They have other medical things going on. So it's not expected you're doing something all 24 hours of the day, but there are some expectations that things will be practiced outside the session as well. Obviously, for someone who it wouldn't be safe to do so, we would help, train family members, train staff on certain things we want them to do. But there is a little bit of an expectation that, some needs to be done outside to best better yourself.
So do I get all of these therapies automatically if I'm discharged from the hospital? Do I get speech, occupational, physical? Am I getting all of that no matter, how does that work? Or is it just
typically it's recommended from the hospital which therapies you get. But the facilities I've worked in, the orders are put in for them to be assessed physical and occupational therapy. For certain, speech therapy is kind of an outlier, and as a speech therapist myself, I kind of can touch on that more. But speech therapy in the long-term care setting, in the rehab setting, works on a variety of things: speech, language, cognition, and swallow. So speech therapy will do a screen of your chart. They'll look through things for any kind of change in cognitive function, change in language function, if someone's had a stroke, for example, or a modified diet, and then that will trigger the evaluation for speech therapy to be done.
So, just knowing a little bit about speech therapy myself, I know it's something that people think, well, I can speak fine, so why do I need speech therapy? Can you get into that a little bit deeper?
Definitely. That quote of "I can speak fine, why do I need speech therapy?" I've heard countless times in my years of doing this, because I usually introduce myself as, I'm Ryan from speech therapy, and that's their first response. So again, speech therapy works on, and this is what my response to them: speech therapy works more than just speech. Obviously, if speech is one part, language is one part. For if someone's had a stroke, cognition is another area. Someone who might have some kind of cognitive decline due to an infection, some underlying diagnosis. We work on executive function, safety awareness, problem solving. In that case, you're able to speak just fine, but you have some deficits in safety that might make you at risk for falling or, further injuring yourself. Our overall goal is to get you better. We want to do everything we can to get there. The other factor that a lot of people don't consider, aren't even aware of, is that speech therapy does swallow as well. So your speech, language, and cognition may be perfectly intact, but you have this swallowing deficit. You might, be on a modified diet from the hospital due to a stroke or due to some sort of abnormality. And that's something that we can focus on as well, since it all is in the same area, working with your mouth, working with your tongue, working with those areas that we do focus on swallow as well. Typically in the long-term care setting, I mean, I do see a lot of patients for cognition, but swallow is one of the big ones. And, one of the things I hear is people don't expect that they could even have trouble with swallowing, that they could have trouble with chewing. They don't know that modified diets are an option to make eating easier for them. So that is something big that I see while working in long-term care.
And that eating piece is so important,
Yes,
really to be able
that
to.
is a lot of what people say is, especially if they're very physically impaired and they aren't able to walk, they aren't able to get beds. A lot of what I hear from people is looking forward to their meals, looking forward to their family bringing in their favorite food. And then when that eating piece is kind of not taken away from them, but limited, it's one of, the things that they look forward to. And now that's something that's been affected as well, as not something that people always consider. It's easier to visualize trouble walking. It's easier to visualize trouble getting out of a chair. It's not easy to visualize trouble swallowing. So it's not something that people typically think about.
Yeah, it's one of those things you can see when a person, if they've had a stroke, you can see that, but you can't
Yes,
understand how it's affecting something that you can't see. That's insane.
exactly. That's exactly.
Yeah, what an important role that you play, Ryan, as a speech, pathologist that works, with the people that are aging or people that have, returned from a hospital and may have some other conditions going on. So thank you for what you do. Really appreciate it. So I want to, so I'm there in the facility.
Yes.
And I've got speech therapy and maybe I've got physical therapy going on and maybe occupational therapy. How do I get to and from these appointments? I mean, how do am I expected to get there by myself? Is somebody going to take me? Is my family expected to take me? Like I would if I lived in the community, I'd have to arrange for my own transportation, right? So I do have to do that in a facility as well, get myself to the therapy room.
Yeah. So the answer to that is kind of all of the above, depending on the level of assistance someone's needing. The good thing about being in a facility is everything is right there for you. You're not worrying about driving to an outpatient center. The therapy gym is down the hall. The facility I work in, it's one short-term floor where the therapy gym is. If there's someone who needs a lot of assistance to get out of bed, we will coordinate with CNAs or nursing to help get a certain resident out of bed, or we, the therapist, will do it ourselves and then bring them down to the gym. If it's someone whose family is there, and family often likes to be part of the therapy sessions to kind of see how their loved one is progressing, we coordinate with families to have them bring them down to the gym at a certain time. And then again, if it's someone who is more physically able, walking wise, or even wheelchair mobility, they're able to propel their own wheelchair down to the gym. That's another key aspect of promoting their independence. We'll let the resident themselves know, I'm going to be in the gym at 11, wrapping up with another resident. If you want to meet me down at the gym at 11:10, and they can propel themselves there, again, to promote their own independence. Independence is kind of our key, as long as it's done safely, and we try and do as much as we can to help with that. So again, all of the above, depending on what the level of assistance is needed.
So this is scheduled. It's not just kind of like, oh, I don't have no idea as the person myself when I'm supposed to go to therapy. So I want to stay in my room all day long because I might be afraid that I'm going to miss the therapist coming in and then I'm going to miss my therapy appointment. I shouldn't have a scheduled therapy appointment, correct?
Each facility, I've been in a lot of facilities with the company that I work with, before being the rehab director. Each facility kind of does it in their own different way. I've been to some where it's the exact time is scheduled every day and they coordinate with the other departments in order to make that work. They'll get the schedule the day before for their time. My PT is at 10, my OT is at 12, my speech is at 1:30. I've been to other ones where it's harder to coordinate based on if they have a dialysis in their center, or if people have a lot of appointments, that the therapist the day of will stop by each room and coordinate. Does 1 o'clock work for you? So they'll kind of know the day of to be prepared. Some residents like a set schedule, so we will provide that to them, or families like a set schedule. If they want to see how their loved one is doing in therapy, they hear that they're getting it, they want to know what they're able to do. Kind of seeing it actually happen is better to understand how much help they're needing versus hearing about it over the phone in a meeting. Actually seeing, this is how we help them get out of bed. So we'll set time with the family to do. A lot of the residents, at least in the short term, those residents know that they are here for therapy, they kind of will typically be ready for it as needed. In the one that I'm working in now, we'll kind of give it a general time so they know if family's coming, for example. We'll say, I'll see you after breakfast. It could be a general range, or I'll see you right after lunch. But the schedules do vary just because everyone, again, has their own medical needs going on. You know, people have doctor's appointments, people have things scheduled that sometimes sticking to a therapy schedule, and we do our best to be flexible because obviously we don't want things missed. And if we set our time at a time, you have a doctor appointment, you know, we have to be flexible too, because that doctor's appointment is just as important as our therapy session. So, and ours is easier to work around because you're staying here living with us, whereas they have to be sent out to a doctor's appointment. So we do our best to give times, but sometimes, you know, flexibility is also a key factor working in this setting.
And that sounds like that's one of the advantages of going to a rehab, a facility for rehab, as opposed to being home, because that getting to and from would be a lot easier for me, because I wouldn't be dependent on necessarily a car transportation and all of that to be able to make my therapy appointments. So my chances of making sure that I get all my appointments would happen much more readily, because I may just be going down the hall, or I may just be going to a basement, or I may just be going upstairs or whatever.
And definitely we make our best effort, because obviously from our staff's perspective, that's the reason some people are here and the reason they're trying to do all this. If you're busy in the morning when we go, that's not the end of it. You missed your session. We go back later on in the afternoon. We give it as many attempts as possible. The goal is to improve in your function. So it is easier than, you know, getting out of your house into your car, going downstairs, driving to an appointment, and then doing the reverse to get back home and repeating it again 2 days later. It is more readily available, and we are here again to make sure that you get the most out of your time here with us.
And I do, you know, I think that's great. And I do want to encourage, as ombudsman, you know, we're very much about empowering people. Mm-hmm. And empowering those who live in long-term care, so that, you know, if you do have any particular things that are going on in your lives, even if it's that bingo's at 3 o'clock on Wednesdays, yes, and you want to go to bingo, then, you know, you make sure you tell the therapist, I don't want therapy scheduled at 3 o'clock because I want to go to this activity. Or my daughter's coming in and I want to sit and have a cup of coffee with her and relax, and I don't want therapy then. So I think that's important that we all hear that as family members and residents, that it is about our lives. You know, that's a very important thing, that we should feel empowered to articulate what it is that we need in regards to this therapy as well.
Yeah, I would definitely agree with that. It is, you know, just definitely to let us know is helpful to us when, you know, if we can fit in our session before a family member is coming. But oftentimes, you know, with these last crazy years of COVID, you know, the things are finally getting back to some normalcy, and, you know, people are visiting more readily and compared to what it was 2 years ago. So we definitely do fully understand that, especially in the times when visiting was far more strict. We know that they didn't always have the option based on how things were going COVID wise. We wanted to fully respect that, you know, this is their time that was set aside for family. So coming out of that last 2 years, 3 years of things, it is, you know, far more, you know, understanding. And like I said, we're there for the day. You definitely have the visits, and we can check back. Just because you have something doesn't mean it's missed. We will try again with a time that works best for you.
Well, I used to encourage in some of my past roles for the families, I mean, for the resident as well as for the therapist, you know, like even for the resident themselves, to get that activity schedule for the day and say, you know, for the next day, and say, you know what, tomorrow, this is what I've got going on. These times don't work for me. Any other time is good for me. And that's when I would like therapy to happen, and vice versa, for a therapist to say, is there any time tomorrow that is not a good time for you, so that I can be mindful of that and make sure that we schedule accordingly.
Definitely.
Open communication can be very important.
Open communication is key on all parts, so we can make everything work, as, you know, in everyone's favor.
So as a family member now, am I allowed to go to therapy with my loved one, with my resident?
We do let family in, you know, the setting I work, we kind of have a window. The therapy gym is kind of an open glass, so you can see some choose depending on the resident. Some residents are a little bit more hesitant. They don't want to be watched to struggle, and we respect that. If they don't want their family member there, then we do let people know that they want to just do it without being watched. They don't want to feel like they're being criticized because they can't do something but other ones like to have their family there, and we encourage them. We have chairs. I mean, the gym that I'm in currently is a bit smaller, so the room is sometimes limited. But we do encourage if families visiting and they want to see how they're doing, we can bring them out to the gym, or we can do therapy in the room if they don't want to, be around other people in the gym when they're, being watched. But we do encourage either way. If they want someone to come and see how they're doing, we definitely allow it. If they want to just be seen without their family there, then we will, either schedule a different time and the family's not there, or if the resident wants to come and their family's there, then we do that too. But it's kind of up to what the resident themselves wants, if they want to be watched while they're doing it, or if they want to do it and focus on their therapy, not worrying about someone, watching the tasks that they're doing. So it's all dependent on the person.
And so Ryan, that answer really, really makes me very, very pleased, because the resident comes first. It's what the resident wants. And I know many of us family members, we do love our loved one, but it is about what they want, not necessarily about I might want as the daughter of, they might not. For example, I did have my stepdad who was in a long-term care facility, and he was in rehab, and he wanted to do it on his own. He didn't want my mom there. He didn't want me there. He didn't want anybody else there, because this was his time with his therapist to work on what he needed to work on, and he didn't want any other distractions there.
Definitely.
And you can really see about, I love to hear that you're really honoring what the resident wants. So that's a message that I think is important for many people to hear in a variety of different contexts. So that's great.
Yeah, I do feel like sometimes residents do feel like if their family's there, that they do want to kind of push to see them during their therapy, and it's just that open communication, and it circles back to that too. If you don't want them there, then let us know, and we will do your therapy again at a different time when they're not there, or we can give them an update after if you're okay with that on how you did, without actually being watched in the session itself.
Oh, that's great. How long would I expect, and I want anybody else, if you want to ask a question, please raise your hand. I just have so many that I'm asking.
Ask any question.
Yeah, please raise your hand or unmute yourself and interrupt me. Please do feel free to ask any questions that you would like. This is a question that I hear a lot of. I get 100 days of therapy. Why aren't I getting 100 days of therapy? Per Medicare, I get 100 days of therapy. Why did they stop me after 30?
That's a question that I hear a lot too. So people, again, that's just kind of a Medicare guidance. People are allotted those 100 days, up to 100 days, as long as they're meeting criteria to still qualify for those days. Criteria being functional progress. Obviously, if you started not being able to get out of bed and now you can stand and walk a couple steps, you go from walking a couple steps to walking 20 feet. Progress is key in justifying the more days of Medicare. As soon as someone starts to get to a level where they're kind of reaching a plateau, where 2 weeks ago you were walking 20 feet and here we are 3 weeks later and you're still walking 20 feet, that's where it becomes difficult to justify using more of those Medicare days without any significant functional progress. We do our best to progress people, kind of keeping that in the back of our heads, that we need to show that progress, but it is, you're open to those 100 days. You have to show the progress to continue to use those 100 days.
So do I get 100 days every time I go to the hospital, or do I have 100 days in a month, or 100 days in well, that doesn't make sense. 100 days in a year. I mean, what can you just?
So those 100 days. Yeah. So the 100 days is, it starts from a qualifying stay in a hospital. So a qualifying stay is considered 3 midnights in a hospital, and then you're transitioned to a rehab facility. If you've never been to one before, you're starting fresh with 100 days. Say, for example, you only use 30, and then the Medicare days stop and you're transitioned to a long-term care. If you're have a 60-day wellness. So 60 days of not being in the hospital, or you go home after those first 30 days in rehab, go home and you're in your home for 60 days, your 100 days will restart. You'll start fresh at another 100 days. If you are with us in rehab for 30 days, you go home and you're back in the hospital 2 weeks later. When you return to us again, you'll only start with those 70 days. So the 60-day wellness is key to kind of refurbish or restart those 100 days. If you're go home again, after with this for another month and you're back in the hospital 2 weeks later, now you've already used 2 months of those 100 days and we're only left with those 30 days. So the 60-day wellness is what kind of restarts those 100 days, 60 days of not being in the hospital, 60 days of a not skilled need.
And that sounds like that's a really important piece of information for people to know. I noticed, Megan, you have your hand up. If you'd like to unmute yourself, please feel free.
Okay. Are you able to hear me?
Yep, we can hear you fine.
Okay. All right. So here in the hospital, what if somebody is under observation status and wants to go to rehab? How does that work for a patient? As well as we've had a lot of discharges from the ER, so that's not staying that 3 days or 3 nights and then going to rehab. So how do those two scenarios play out?
So with someone with Medicare, again, things have been different in the COVID time. So at least just looking on the last 3 years, they've had that waiver where if they're just an observation and not admitted for something along those lines, there's a waiver that doctors can sign to kind of bypass those 3 days. So if they are only observation for 1 or 2 days, they do have some form of rehab need, then the doctors can sign a waiver to kind of bypass that in COVID times. And they need to check the obviously if the person has Medicare, they need to kind of check with that. If it's an insurance patient, then we can, even if they're only there for observation, we can submit for insurance authorization when they do come to us, and then try and get them skilled that way to get them as much therapy as possible. So kind of depends on a case-by-case basis.
That was a really great question to ask, a really important question to ask, because I know that that's a situation that can happen quite frequently to people. And if anybody is a little reluctant about unmuting their microphone and talking, you can also type it into the chat, and Stephen will make sure that we're aware that there's a question in the chat as well. Stephen, are there any questions in the chat currently?
No, there aren't any.
Okay, great. I wanted to talk a little bit more then about this. You talked about this assist versus setup, and can you explain what that means?
Sure. So there's multiple levels of assistance that someone could require. So obviously the most independent, they do it completely on their own. In that situation, they likely aren't in long-term care if they're independent. The next one is considered a setup, where feeding, for example, the food items are opened and put in front of the resident. They feed themselves physically on their own. Setup for dressing might mean they get the clothes out of the closet and hand it to someone. They do it on their own. Then it progresses into kind of needing some physical assistance. So if they're needing minimal assistance, they might give them some verbal cues, physical or verbal assistance. They would give them cues on, let's put on your shirt, and they might, start the process of putting the hands through the sleeves. It then progresses, more and more on how much assistance you might need to someone who would be requiring the most assistance, kind of being a total assist, where if they're total assist for dressing, then staff, nursing, or CNA would get someone dressed in their entirety. Staff would feed someone their meal from start to finish in their entirety. It's kind of a progression based on each ADL, each care need. Again, you might need setup assistance for feeding. You can do that all yourself. You might need total assistance for dressing. You're not able to physically dress any part of your body. Each ADL has their own level of assistance required, and each aspect of an ADL can be broken down. Again, like I talked about earlier, you could be able to dress your upper body completely independently and need total assistance staff to dress your lower body.
And so should I expect it? So you said staff. So the expectation is if I can't do it myself, that the staff would assist me with doing that. It's not the family member's responsibility to come in every day and make sure the person's dressed and the person.
Correct. It would be the staff being the CNA, nursing. If they're on therapy, then we assist with that as well. The staff will do or assist with any ADL task that you aren't able to do on your own. Again, that doesn't mean family can't help if they choose to, if they want to. If it's a family member who visits every day and they prefer to feed their loved one breakfast, by all means, they can do so. We're not going to stop them from doing so unless there's some kind of safety concern going on. But we as the staff, the facility staff, will assist with any ADL that the resident is unable to do on their own, or any portion of the ADL that they might need assistance with.
So I want to make sure that I understand this assistance properly. So if I need assistance with dressing, it may just look like I'm picking out my own clothes, and the nurse's aide will maybe then put those on the bed for me. I might put my shirt on, but they may button my shirt for me. Or I may just put one arm into the sleeve and then they put the rest of it around. Is that kind of what that looks like?
Correct. And any task, like you said, for the shirt, for example, any task can be broken down into multiple steps. Kind of like you said, if you're able to put one sleeve on but need help with the other because you have an issue with one arm versus the other, you can put your arm through in the right sleeve. The staff will help you physically put on the shirt on the left sleeve. If you're not able to do the buttons but could do a zipper, we would button it for you, but now you have a zipper jacket, you can do that on your own. Each thing can be broken down into further steps that you aren't able to do on your own.
Okay. And so when it comes to, those things, it's really then the expectation is that for the most part, it should be the CNA, the nurse's aide helping me do it. The therapist is not going to come in every morning to dress me.
It depends. If it's someone who is there for short term, or even a long-term resident who's there on therapy, and we know that resident or patient likes to be seen in the morning, we might start their day with occupational therapy, and they could be focusing on dressing, they could be focusing on hygiene. If they prefer an early session, the occupational therapist could be the one dressing them each morning while they're on therapy. If they're not on therapy, then yes, it would be the nurses or the CNAs who have to assist with that. So it kind of just depends on the person themselves, how they want things, how they want their day to look. But it could be the therapist if that's something that dressing is a goal that they're working on. Then, and again, like I said, they like to have a morning session. We can work on dressing each day, and they can assist you in getting dressed.
Okay. So how do I know exactly what I'm supposed to be having done for me, what I'm supposed to be doing? Is it written anywhere? Do I have this in my charts? How do I know what I'm working on, what my goals are? How do I know all of that stuff?
So from a short-term standpoint, we, as the therapist, will let you yourself know, we'll let the families know in a meeting after the first couple of days. Like I said, our goal is to get you back to what you were prior to a hospitalization. So we will create our goals on that day one of the evaluation, and then meet with the resident, meet with the patient, meet with families to discuss, these are the things that you were able to do before that, you were hospitalized, before you had this decline. These are the goals we've established in therapy to try and get you to those points. So we'll explain it out to the residents and their families to make them aware of their goals, to make them aware of what they're working on.
Does this get written into my care plan as well?
It does, yes. And what need you might, again, need for each ADL, feeding, dressing, bathing, it's all care plan, and the care plans are individualized to the patients. I mean, no one's care plan is the same as the next. It's based on your level of need, your level of assistance, and it's all documented. Yeah.
And I can access that care plan. I can request to see that care plan if I'd like. If I wanted, my daughter might be coming in from out of town, it's going to be on a weekend, I can ask for my care plan and then use that care plan to show my daughter what it is that I'm being worked on. Is that appropriate?
Yep. All residents or their power of attorney can request any medical records from our facility, and we would help facilitate that. If the resident themselves is okay with us just telling their family, if it's easier for us to explain it versus the resident explain it, we can also explain it to them. Sometimes reading through, the different medical terms on a chart might be hard for someone who doesn't fully comprehend it all or understand it all. So we can also, provide that information if it is requested, and then explain it to them as well to clarify anything.
And that is something that through the Ombudsman program, I know we really do try to encourage people who to get a copy of their care plan so that they can feel empowered with that information and know what's going on and be able to kind of understand the treatment process better. So what's one thing that we really do try to encourage for people to do, and it might be a good thing for people to kind of put in their back pocket. And remember, this is the plan of care, your care plan. It's a service plan if you're in assisted living. It's something that is mandated to be done. So there is for everybody who's in a long-term care facility, a skilled or immediate care facility, there's some sort of plan that you should be able to access so that you know what type of care you should be getting. I see that Stephen has his hand raised. Stephen, can you? Would you like
Yeah, so we had a question in the comments, and it's who is responsible for making sure ADLs get done when the resident cannot remember, needs to do because of cognition issues, and the resident also requires help with every task in life.
Okay, so the responsibility falls to the staff working with that resident. So the CNA we're all familiar with the residents that they are following up with. They all have, like I said, have the care plans established on what they need help with. So the CNAs would follow through on each task that is needed to be done for them. And if they need something, like you said, they need help with every task of their life, then again, that would be the staff who is caring for them. The CNAs obviously then have the nurses on the floor as well to, they're doing the medication, the medical aspect, but they oversee the CNAs and make sure that the tasks are done for each resident, no matter how much assistance they might require or how often they need assistance. The staff is there and aware of their needs, and they will, tend to them daily as the needs arise.
So especially, it sounds like if the person does have some cognitive issues, one day they might be able to do something, the next day they may not be able to do something. And so the CNA has to be very conscious about that to make sure that because I really love the way you talked about this, regaining, making sure that we're promoting that independence. And we're trying to keep loss of functioning from happening.
Definitely.
Yeah. Well, and I was going to say, it's typically not everything that a resident needs help with. They might need help with one aspect of it. Well, like Lee, you were saying earlier, person might need help with their pants, but they can do their shirt. And so understanding where that line is important. And then understanding that the line can move from day to day.
Mm-hmm.
Definitely. Yeah. People do fluctuate. Obviously, if there's something medical going on or just with any graduates of kind, people fluctuate day to day and the level of assistance might change day to day. People who are there for short term, obviously were hospitalized typically, and they will need different level of assistance based on each day. And we try and look for kind of a general progress, where someone is there for long term. And if something medical going on that could cause that decline, is there something, what is causing that decline to happen and how can we best address it? But people do fluctuate based on their need and, which aspects they might need help with on a given day.
Yeah, I've seen a lot of that really around like mealtime, a lot of time in working with people with dementia. They may not be able to cut the food, but they could take a fork and they could, stab that piece of meat and be able to navigate it towards their mouth, but then they may need a little assistance getting it all the way into their mouth.
Correct.
I've seen things like that. So, and I also would encourage, in that same breath being said, to look at, are there any tools that we could sometimes use to encourage that increase in our independence? Are you aware of any tools, Ryan, that might be out there?
There are different things depending on what area you're trying to increase. So for some people, they might just need a visual reminder. They might need a sign to help promote that independence. They might need a verbal cue to start their meal, and then they'll feed their whole meal themselves. Other people, if there's different adaptive equipment, then you can use too. You know, for someone who has trouble holding a spoon, you can have a built-up spoon, a wider spoon that's easier for you to physically hold. So it's not just stopped right there because they can't hold this normal spoon, they have to be fed. We can get them some kind of adaptive equipment. So although they can't do it with a regular spoon, with this built-up spoon, they can do it, and it still promotes their independence with that adaptive technique.
That's great. And that sounds like something that we really should take a look at. As a family member, sometimes if my loved one has been in long-term care for a long time and they're not being seen by a therapist because they're in long-term care now. And if I'm seeing that there's some changes happening around eating, is there anything that I can do? Can we get a therapist to come and evaluate? Is there someone else I talk to? What do I do about that so I can promote that independence in the activities of daily living?
Yeah, so we didn't touch on it earlier. So when the therapy, so for kind of like we said, if someone is in long-term, therapy has ended and now they're just residing in long-term care. From a therapy standpoint, we establish what's called a restorative program that we endorse to the nursing and CNAs with the main goal of maintaining all the function, maintaining the independence that we were able to gain while they were working with the therapist. So the restorative kind of works as a guide to assist each resident to achieve their highest level of independence. So we lay out these goals and then we endorse it to the nursing when the patient or resident is no longer on therapy. Again, the concept focusing on their, maintaining their function. So from the aspect on our end, the staff, be it the restorative nursing, the restorative aid, the CNAs or nurses on the floor, they are aware of the level that the patient's at, and they will, if they see any decline, they used to be able to feed themselves, now they can, it'll refer back to us. That doesn't mean that also family too, family knows their loved ones and they could visit every day and they notice that, now they're not able to feed themselves. They again could let the nursing know, my mom was able to feed herself before and she seems like she's needing more help. And then the referral process can get started that way. Just because therapy ends in a long-term setting doesn't mean it ends forever. It's kind of a revolving door. Should a decline happen 3 months after we stop therapy, then and now they're needing more assistance, we can step right back in with, working with the families, the doctors to get that order back to start therapy for walking. They're not walking as far, to start therapy for toileting, they're having trouble going to the bathroom, needing more help with going to the bathroom. It's a ongoing process that kind of bounces back and forth between staff. The communication is key between the facility staff as well as families as well as residents to keep that door open, that therapy is always there should you need more assistance with something.
And all of that, Ryan, everything you're saying there makes complete sense. I'm really hearing that strong thing about communication. And just because somebody may not be in therapy anymore doesn't mean that they might not still have a need. And if there's a recognized need, speak up, talk
Definitely.
to somebody and get some action happening. I know personally, I have seen that happen a lot around the mealtime experience, where somebody was able before to be able to pick up their own cup and take a drink. Now they have difficulty, they're shaking, or just even that being able, that motor to be able to grab that coffee cup makes it more difficult for them. And then they're spilling and they get frustrated. So there's things that can happen there, correct? To make that experience for me better. I might not need therapy. I just may need somebody to come in and take a look and give me some techniques or adaptations.
Exactly. And yeah, it doesn't have to be, the therapy may not be as intensive as it was when you first came in as a short term. It might be, just a few times a week. It might only last for 2 weeks if it's just to, again, assess for an adaptive equipment. If it's a strength issue, then we, work on strengthening to help rebuild your ability to do whatever task you aren't able to do as independently as you were before. So it could even just be, like you said, we could screen them and maybe just offer some insight and then monitor and follow up to see if these things are still happening, or is there a medical reason that this is happening that needs to be addressed first that's causing this decline, to then determine, is it an actual decline or are they just having trouble because they have something medically going on?
And that's important to make sure that there's not just something medically going on. It's not just a matter of just as I'm aging that I'm losing a little bit of ability. There could be something going on with me.
Yeah.
And that's, I think, an important message to hear. This promoting of independence, I think, is a very strong message for all of us, particularly on this call to hear, because that's the benefit of being in a long-term care facility, is somebody to be mindful of what you can do and what you can't do, and not to take over, but to help see if there's a way that assistance can be provided so that you can maintain some of that independence, which promotes self-worth, self-value, the ability to be able to do is an important thing to hear.
Definitely.
Yeah, I really do appreciate everything that you've said. I'm looking to see if I have any other questions here. And I think I've got most of my questions answered. I don't know if anybody else has any questions that they would like to see, or any personal experience that they would like to share in regards to any of their engagement between activities of daily living or with therapy. Please do feel free to unmute yourself and ask that question or provide us with that story or that comment. Anybody has anything? Oh, well, while people are maybe potentially looking to see if they've got any, Stephen just put himself on the screen, so I think Stephen might have a question.
Well, it's more of an observation, really. What I see a lot, I'm an ombudsman in the Quincy area, and what I'll see is people will get booted off of therapy because they're, quote unquote, not participating. And when I'm digging down with them, trying to figure out, why were you booted off of therapy? Some of the time it's because, in talking with therapy, it's because, well, they wouldn't do therapy, and you talk to the resident, they said, well, it hurt. I was in a lot of pain. And so something to remember is, yes, therapy does hurt. There's going to be some pain involved because you're exercising muscles that need to be strengthened. But if you are experiencing pain, it's important to communicate with your physical therapist and let them know exactly what's going on so that they can work with you and work with the pain rather than just stopping therapy. Because when people stop therapy, that's when the therapy benefit ends.
Ryan, is there anything that can be done about that, about that pain issue?
Yeah, so I mean, definitely, our goal from a therapy standpoint is to progress, is to improve function, is to promote that independence. If pain is a limiting factor, we want to work with a team to see, one, what's causing that pain, and two, how we can coordinate to limit that pain as much as possible. As you said, some pain is going to might be expected. Obviously, some discomfort might be expected working on things you haven't done before, but we would coordinate with nursing to make sure, are you due for a pain medication before your therapy session? We want someone to have the most benefit of their time with therapy. And if they're not doing it because of pain or not able to fully participate because of pain, we would coordinate with staff, coordinate with doctors, with nurse practitioner to make sure they're getting what they need to alleviate some of that pain in order for them to be successful. We want success in their therapy. We want them to progress. We want to do what we can to help them progress in any way that possible.
Yeah, I've even heard of some facilities doing even like some scheduled dosing, maybe, some over the counter like Tylenol or something along those lines prior to therapy to help take that edge off of the pain, or to be able to give the person greater ability to be able to advance themselves.
Definitely, communication with nursing is key. We're not just our own entity in therapy. Nursing is not their own entity. We all have to work together, again, with the end goal of progressing someone, promoting independence as much as possible. We do coordinate with them to, I'm going to see them at 10, maybe they can have an Advil or a Tylenol at 9. Like you said, to kind of take that edge off to help them do as much as possible. Again, our goal is to progress them. And if they're not progressing, we need to figure out why and how we can change that so they can benefit as much as possible.
That's great. Stephen, is there another question?
Yeah, so in the chat, Nancy Cobb asked, often CNAs are very busy and may not be able to respond and provide alternative for ADL. What's an alternative?
Nancy, could you explain that a little bit further if you're comfortable unmuting yourself? Are you comfortable unmuting yourself, Nancy?
Yeah, I think that a lot of times there doing so many things and taking care of so many people, and you say, you say something to the CNA as a, I'm a volunteer ombudsman, is they may say, well, we'll try to get to it. And, unless you're there to follow up, you don't really know if they're getting, that alternative support. And that would be true of anybody that's out of the facility. You just can't be there. So I just often don't see that they have time to accommodate a lot of things. And it's easier not to accommodate things. And I mean, CNAs are wonderful and they have a really hard job, but the reality is they're really busy and understaffed.
And that, I think what you just said is the key to that, and the answer to that question. What's an alternative? Staff hiring. I think this is critical. You can never expect one-to-one care when you move into a long-term care facility. That's not what this is. It's not home care. It is long-term care where there is a ratio of staff to residents. But when we get good quality staff with good quality care, it can change things. It's particularly in regards to this ADL arena. So that staffing issue is probably the barrier. And I don't think Ryan has a magic wand for that. Ryan, do you?
No, I don't. I wish I did, but I think something that you said really is important, that long-term care isn't a one-to-one care. People, I think, sometimes do misinterpret that, just because we do have 24-hour care services. We do have 24-hour nursing. We do have 24-hour caregivers. It's not a one-to-one service. I think that's something that's hard for some people to wrap their head around at times when they're moving into a long-term care setting. They move in with that expectation that someone will be with them all day, every day. Yes, there are staff on the floor, but like you said, there are the staffing ratios. We are doing, they are doing what they can, but I don't have any magic wand to fix that. I wish I did. Families at times will have their own personal caregivers come in. Obviously, we don't require it, but families sometimes feel more comfortable just having that extra set of hands, extra set of eyes when they do feel that they are needing more help or are needing something like a one-on-one care in addition to the 24-hour staff that we have in these facilities.
And I don't want to minimize anything that Nancy said, because it's very, very true. This is a very real, ongoing issue that occurs. And this is, I think this is like the, the $24,000 question or whatever that, however you say that, because this is a big issue. Not being able to get that ADL care that I need, I want, and I deserve when I move into a long-term care facility. And what is the alternative? What can I do about this in order to be able to feel honored as that individual as I should? And I don't know if there's an easy answer to that, Nancy. I really wish there was.
Well, I want to throw out a couple ideas here, and I will note that we are at 4:00, but there are different levels of ADLs. There's getting changed, there's getting up and going to the restroom. Sometimes there are things that devices that assistive devices that can help a person. And I can't remember the name of the place, but there's a place in Springfield, the Illinois Assistive Device Program, that has a lot of those that a resident and their family members can check out items from them. So it's not necessarily a good alternative, and it's definitely a case-by-case situation, but they have items that might be able to help people. Also, like, if sometimes I just want a fan on, and for a person who's maybe bedbound in a nursing home, that can be impossible to do. You have to put on your call light and wait. Or if you can speak clearly enough, you can say something like, Alexa, turn on the fan, or Alexa, turn off my light. Alexa, turn on my light. So
she's listening to intently.
So sometimes there are some things that that we can, find an alternative to that can help.
And
That's perfect.
I've even in the past have encouraged, if I have a resident who may need more hands-on assistance and they're sharing a room with somebody who may need more verbal assistance or just set up help, to set that person up while I'm giving the care to the other person and be able to do that oversight that may need to happen for the person who's more independent while I'm actually engaging in the care of the one who needs my hands-on assistance. And you're trying to use that technique and encouraging nurses, aides to try to broaden that horizon a little bit and look at the care of their roommates and see if she could be picking out her clothes while I am dressing this one. And then this one could be picking out her socks and shoes while I'm helping this one get dressed. So trying to still do some encouraging of some independence there as well, because I think the message that Ryan really tried to share with us today is about therapy, activities of daily living. It's all focusing around that promoting of independence. What we'll do now is I will go ahead and leave and stop the recording of the session. So I just want to thank Ryan publicly for participating today. And after I stop the recording, I think Stephen might have another question to ask just me.
Thank you. Thank you for having me.